is prostatic artery embolization and when is it needed?
So prostatic artery embolization is a procedure that is designed to treat patients with symptomatic enlarged prostates and what we term as lower urinary tract symptoms. Urgency, the need to run, frequency, having to go multiple number of times, having to wake up in the middle of the night, or a feeling of having to put extra pressure to pass your urine. So this is a set of symptoms called lower urinary tract symptoms. Prostatic artery embolization is designed as an alternative treatment to conventional surgery, whereby what we do is we, instead of removing or coring out the prostate tissue around the urethra, we go into the blood vessel of the prostate, right? And we take off the blood vessels. So we close the blood vessels, a process called embolization. By that process, what happens is the prostate is devoid of its blood supply. So it shrinks, it gets smaller. So the pressure on the urethra lessens. So prostatic artery embolization is, in summary, a minimally invasive without cutting procedure designed to relieve symptoms of lower urinary tract symptoms as an alternative to the more conventional surgical transurethral resection of the prostate gland.
How is prostatic artery embolization different from conventional modality of management?
Traditional conventional way of treating an enlarged prostate is by a transurethral procedure. So in the very old days, the entire prostate is to be removed, prostatectomy. There is a risk of urethral complications like stricture or incontinence, retrograde ejaculation. So these are various urethral complications of a transurethral surgical resection of prostate. Prostatic artery embolization, on the other hand, is done from the groin like a conventional angiogram. You're going into the artery of the prostate, so you're not touching the urethra, and you're reducing the volume of the prostate gland. So basically, it will give you a similar effect as to take out the prostate tissue surgically, but without the transurethral complications or the risk of bleeding and infection.
What is your clinical experience on the result and the present literature evidence for this procedure?
Now, over the course of the last 15 years, now there is enough randomized data to suggest that prostatic artery embolization is equivalent to surgical treatments of transurethral resection. There are even randomized data including what is called sham procedures, in which one half of patients had this procedure and one half of patients had a pretend procedure without the embolization, in which it is shown that the ones that had the embolization had a much superior effect. Our hospital in the UK were also part of the UK ROPE trial, and that trial also compared prostatic artery embolization to transurethral resection of prostate and showed it to be a non-inferior procedure, which means that it is at least as good as transurethral resection of prostate. When you compare these two, the transurethral procedure and prostatic artery embolization, one clear fact that emerges is that there is better ejaculatory function, sexual function preservation with prostatic artery embolization compared to the transurethral procedures.
What is radial approach and how is it beneficial for the patient?
Instead of puncturing your groin, and going into the prostatic artery, you can come from your radial artery, which is the little artery here, and like the cardiologist, you can go down into the prostate supply and you can do the embolization. So the great advantage of the radial approach is that you as an operator is standing a little bit away from the radiation, so it is good for you as the operator. But the main thing for the patient is that because there is no need for a bed rest, you are immediately up. You can do this as a day case procedure. Your hospital stay requirement is lessened and there is less amount of bleeding because the groin can potentially have a more amount of bleeding. And also, it is overall very much more patient friendly.
What is your message to the general physicians about managing the patients in their OPD settings post-procedure?
My message to my general physician colleague is to give this as an option, but to understand the procedure so that the patient can choose and the patient is given all options laid on a basket rather than one specific advice, so that we can do the best for our patient.